Greetings and a very warm welcome to our 7th annual meeting of the Community of Practice on Scaling Development Outcomes, and to today's session on fragile states, focusing on innovative approaches to scaling at the last mile in the hardest places. My name is Jonathan Papoulidis. I co-chair the working group on fragile states at the Community of Practice with my colleagues Rob Chase at the World Bank and Pallavi Roy at SOAS ACE at the University of London. I'm also on the steering committee for the COP. And so let me first start as moderator of today's session by welcoming back to the program our existing members, which now number about 2,500. Let me also extend a special welcome to those of you who are not members of the COP. We hope we will enjoy today's sessions and encourage you to see some of the other ones that we're doing during our annual workshop this week. The Community of Practice was established to advance and professionalize the practice of scaling through shared learning across various sectors, geographies, and themes. We are entirely free and voluntary, and so the strength of our community depends very much on the quality of active participation. New voices always strengthen us, and so we warmly welcome you to join if you see interest and have an abiding focus on scaling. We also have, in addition to the annual workshop, a quarterly newsletter that goes out. We produce knowledge products throughout the year, and we have 9 working groups, including this one. Our website is www.scalingcommunityofpractice.com, and you can also reach out to us at info@scalingcop.com, and we'll make sure that those links are available in the chat box. Now, turning to the subject of today, looking at fragile contexts and scaling, the last few years have been particularly hard on fragile places. The global pandemic, soaring inflation, high and acute food crises, the war in Ukraine, and other conflicts that are increasing have all taken the greatest toll on fragile places. And so the solutions that are needed are particularly in high demand right now, beyond projects, beyond piecemeal interventions, and towards much more scalable solutions, especially those that can reach the last mile, the hardest places, the most vulnerable populations. And I can think of no better organization to help us think through and get a window into the complexities, challenges, and opportunities of scaling at the last mile in these places than Project Last Mile. They are doing some of the most innovative, important, and collaborative work in our aid sector to get to the last mile with health solutions. And so we're delighted to have them here today. In particular, we have Alexandra Scott, who is the president of the Global Environment and Technology Foundation and Managing Director of Project Last Mile. We have Rushika Shekar, who is the Director of Program Delivery and Operations and manages the Africa portfolio for PLM. And we have Jose Neves, who is the country lead for PLM in Mozambique, and who comes to the portfolio with 25 years of experience in Coca-Cola in various executive roles in various African countries. So we're delighted to have them all here today with us. And 2 more notes before I turn it over to Alex to begin the presentation. The first is that we are recording this presentation, and we will be publishing it both to our website and to our YouTube channel. So we encourage you to share amongst your own networks. The other thing is that we have a chat box, which I hope will be very active during the session today. Please contribute your insights and comments during the presentation, and also pose questions. We've invited our speakers to answer any questions directly in the chat box that are simple and straightforward. And for those that are perhaps more substantive, I'll pose them to the speakers during the Q&A session. And so without further ado, let me turn it over to Alex to begin the presentation. And again, a warm welcome to today's session.
Thank you, Jonathan. Is everyone able to see the screen before I get started?
Yes.
Okay, fantastic. Good morning, good afternoon, good evening, depending on where you are joining us from. We're very happy to be here and looking forward to what we hope will be a discussion and conversation. Questions are always welcome. Jonathan already gave us quite a strong introduction, so we will dive right in. Our focus and kind of the flow of how we wanted to guide this conversation today in this presentation is to look kind of at 2 focus areas. The first piece will focus on Project Last Mile as a global partnership and how since 2009, when we first started, we have scaled from 2 pilot countries to 15 countries supported in Africa, and continued to grow over that long duration of time. And then we'll dive into country-specific examples of how we've taken the global capacities of Project Last Mile and the Coca-Cola system and applied them in fragile contexts, specifically focusing on Mozambique and Sierra Leone. So with that, I will dive into a bit of setting the context. So Project Last Mile is a public-private partnership. It's a cross-sector partnership that pulls together the Coca-Cola Company and the Coca-Cola Foundation, USAID, the Global Fund, the Gates Foundation, and PEPFAR. And this partnership started in 2009 in response to a question that was posed by Melinda Gates in a TED Talk of, if you can find Coca-Cola products in very rural and remote locations across the world, how can we learn from that and apply those best practices and approaches and whatever the secret sauce is that the Coca-Cola system is deploying to health systems, specifically in Africa? And so that call to action led to the creation of Project Last Mile, which started in 2009 with a pilot in Tanzania and Ghana to really test how we might leverage the models and the expertise that the Coca-Cola value chain brings to, specifically, it started in last mile delivery and demand creation to the health space. And so Project Last Mile works very closely with ministries of health as kind of our primary core partner in markets where we operate, and global donors from the public health space, as well as implementing partners and other stakeholders to achieve three core aims. One is to improve the availability of medicines and health commodities by building capacity around last mile delivery, supply chain, and translating the models that the Coca-Cola system uses and adapting them to make sense for the public health context. The second is to translate the strategic marketing approaches that the Coca-Cola system uses so well to build brands and affect behavior in terms of, connections to their brand, generating sales, uptake, engagement with the company, love for the brand, and apply that to the public health space and demand creation space. And then third is to inspire and support kind of this movement towards leveraging the capacities and capabilities that a business and a private sector partner can offer to bridge that gap between public and private sector. So like I said, the partnership model is a global secretariat of PEPFAR, USAID, Global Fund, Gates Foundation, the Coke Foundation, and the Coca-Cola Company. And each of those core partners play a very critical role in enabling Project Last Mile, both to get started and to have scaled to this point. And it says funding, but it's so much more than that. I need to adjust that. Each of those partners, particularly the donor partners, play a really fundamental role and have played in helping us to make sure that the programs and the interventions that we're designing and implementing are demand driven by opening doors and providing kind of advocacy and endorsement and guidance on the technical needs, the health needs, the health system priorities, making connections and helping to build trust with the ministries of health in particular and the other implementing partners on the ground to enable us to really design demand responsive programs that don't duplicate what other organizations are doing and specifically leverage what Coke system does well, because that is the unique capability that Project Last Mile can offer. There are many other experts working on the ground, and we have been very intentional about creating programs that fit with what's already working. Of course, funding also is a key component of that. And then the Coca-Cola Foundation provides critical catalytic and central funding, as well as specific program funding, which I'll get into because that's been one of the keys for success in our ability to scale is flexible access to flexible funding. And then the Coca-Cola Company provides access to IP, sharing with their best practices and business models are local business intelligence, and a big value add that we've leveraged a lot has been access to their agency network, their vendors, the organizations that they work with, to be able, again, to bring in the private sector approaches across our programs, not just from the Coca-Cola company, because it is really a system. And so we tap into all layers of that. From an M&E perspective, we started with Yale for the first 10 years. Their Global Health Leadership Institute really played a critical role in helping us to understand and communicate what was working about the partnership from a partnership perspective, the process that helped us continue to scale. Seeing that the slides are disappearing. Natalie, if that's also happening for you, if it makes sense to switch over to you showing the slides, just let me know. I can be flexible. And then, of course, the in-country partners are fundamental. So we set up teams of subject matter experts from the Coca-Cola ecosystem and local project coordinators on the ground, but our teams are typically small. They're between, I would say, 3 and 5. And we really are in an advisory capacity, not an implementation capacity primarily. So we are partnering directly with ministries of health, often in an advisory role, local NGOs and implementers through technical working groups and collaboration, and increasingly now are expanding from public sector to also be working with health enterprises in the private sector as well. So like I said, our focus is on leveraging what really are the core capabilities that the Coca-Cola system has that can contribute to what the public health ecosystem already has access to, and how those learnings can strengthen what's happening there. So last mile delivery was the first one, which we've talked about. Differentiated service delivery. In our context, this is really thinking how to support governments to diversify their distribution channels for their public health commodities. So looking at working with retail outlets to connect them to existing public sector supply chains to expand access and coverage for health commodities to patients within the public sector. Cold chain, this became very relevant, as you could imagine, in the last couple of years. But the Coca-Cola system in Africa has over 1 million units of cold chain equipment across the continent, and is striving and often successful in keeping them up and running 95 to 98% of the time. And so was a huge opportunity both to learn from how they've set up their preventive maintenance and how they manage their preventive maintenance and repair, as well as tapping into their network of suppliers who actually conduct that maintenance and repair. And so we've done that now, I want to say, in 6 or 7 markets in Africa. And that's a real kind of key niche that the Coca-Cola system contributes to strongly. Enterprise development, like I said, is now taking what Coca-Cola does to help build its own value chains, small and local businesses, key distributors that are utilized within the Coke value chain, and bring that over to supporting health enterprises. And so that's kind of an early stage effort, but we're just getting into that. And then strategic marketing and demand creation, which I shared as well. Just a few examples of some of the achievements we've seen over the years. So we're now have supported 15 countries. We have delivered over 40 projects. I want to say 46 at this point, and across those markets. And again, we started in 2. So some of the successes we've seen: optimizing distribution routes for over 3,000 health facilities and seeing reductions in out of stocks and cost savings through applying Coke models to public health contexts. Differentiated service delivery right now in South Africa is the main focus there, and that over 5 million patients are enrolled in that program. I've talked about cold chain, and from a marketing communications perspective, focusing primarily on HIV and COVID, have reached over 30 million people through national level health campaigns, seeing both increased uptake in HIV services and COVID vaccination. And we'll get into a bit more, particularly on some of these when we get into the case studies. So I've shared a little bit about this kind of journey to scale. This is just a timeline to kind of show the growth and progression But I think what's most important is to talk through some of the lessons learned around what it took to scale and build this partnership that kind of fits into that. So at the global level, there have been a kind of, I guess we can say, 4 key factors that have been critical to us being able to scale and support so many different countries with similar but different needs, using the framework of the Coca-Cola systems approaches in each market. So the first one has been really having we call it a coalition of champions. But Project Last Mile, when it started, this is both, all of the partners have been on this journey the entire time. With the USA joined in 2014, PEPFAR formally joined in 2018, but funding had been coming through our USAID agreement from PEPFAR, starting much earlier than that. And so all of these partners, we've had consistency in their engagement and their buy-in over the course of, since 2009, really. Started with Gates, played a catalytic role in testing this model. And then once that test was successful and proven, our kind of scaling partners came in, PEPFAR USA, to help scale that. So not only at an organizational level, but also at an individual level, a number of the individual people have been on this journey since the beginning, particularly from Gates and Global Fund. From USAID, we've had a series of different individuals come through, but they've all been true champions of this work, and that's just fundamental to navigating the complexities of working with different donors and partners and being able to find consensus around a common goal. The second is a flexible global hub. So the way we have established Project Last Mile that's been key to the success is by having a neutral platform partner, kind of a backbone organization, which is the Global Environment and Technology Foundation that hosts Project Last Mile. Each partner is equally represented through Project Last Mile, which is represented as a brand in and of itself, and enables us to be quite flexible and neutral in presenting how we work with partners. So we're not representing Coke, we're not representing necessarily any one individual partner. We are kind of a neutral platform with a focus on these objectives, and we're able to use the PLM brand and this flexible arrangement of having kind of a backbone partner to deliver on that. Strategic mix of funding. So I can't stress this enough. I'm sure everyone on this call could appreciate the value of unrestricted funding or less restricted funding. The reality is, working across multiple donors with governments and multiple timelines means that there are bound to be gaps in funding as you're transitioning from phase to phase and looking to continue to build that trust over time to enable our programs in certain countries to scale. And so by having catalytic partners, scale partners in terms of funding, and also central partners who are able to provide kind of a consistent flow of funding that enables us to, for example, if there's gaps in phases of projects that are being funded by a global health donor, we're able to kind of fill that gap by having flexible funding for a certain period of time to ensure that we're maintaining the relationships and at a minimum continuing to provide at least light touch support until we're able to get into that next phase, which is critical to us having been able to scale in those markets. Yeah, I mean, I can go on about that, but also to say that, you know, when we first started, after the pilots, we started in 2009, our pilots ended in 2013. The global agreement was set up in 2014, and we didn't have our first country program until 2016. So it takes a long time. The lead times are quite significant, and having that strategic mix of funding has been critical. Natalie, I can't remember if you're telling me that means my time is up. I know you told me what it means when you raise your hand, so just shoot me a WhatsApp. So the last thing, driving mutual benefit. I mean, from the Coke system, while it's not a commercial, this is a philanthropic effort, it's not a commercial benefit, but the Coke system employees have reported a motivation and engagement and interest, which has helped kind of generate value and continued buy-in from the Koch system on the value of supporting this philanthropic effort, in addition to the impact that we're seeing, as well as kind of a shared learning, a two-way learning opportunity where the company is able to, the employees in the company are both teaching but also learning through this engagement. So if for the sake of time, keys to success that we've seen, I will kind of tap into each of these lightly. So connecting global capacities to meet local priorities. I mean, that's what PLM is fully about. But the way we have engaged in this model is that we start before any project with an engage and align approach. And this sometimes can go from 6 months to 12, depending on what's needed, which is to intentionally work with the donor partner, the Ministry of Health, and our team to be able to ensure that any project we set up is aligned with what PLM can do, what the Koch system's capabilities are uniquely, aligns with the investment priorities of the funder and the strategic and health priorities of the national health system, which has helped to promote ownership by the government partners that we're working with, of course, preventing duplication and overlap, and complementing other investments that will hopefully sustain and grow that work. Good governance at a country level has been really key, and Mozambique's been a particularly stellar example of that. So I hope Jose will speak to that. Our most successful programs at country level have local governance structures that are hosted, chaired, or at least regularly attended by both the government agency partner that we're working with, as well as many of the nonprofit, the implementing partners in the field that we work with. And that has been key to helping us kind of troubleshoot, promote accountability, stay on track, and also pivot when we need to, if the direction we started is no longer in line with the direction that the government or funder is trying to go. The adapting private sector capacity for public good as a key to success, I think the focus there is about how we intentionally set up our teams in each country to help us scale, to create that focus on growing the work and the impact, even if it's pivoting. And so I talked about, all of our programs are led by Coca-Cola system experts who have, like Jose, worked in the system for a very long time and are now looking to leverage that expertise for social impact and apply that. And we also bring in local coordinators and local teams who have the knowledge of the ministries of health and the stakeholders and the public health context to blend that to the two worlds. And then ensuring transparent use of data. This has been just a really helpful value add for us in building trust and encouraging the continuation of our work, in that we found when we first came in, there's a lot of data out there, but it's not easy to get access to it. And so it's kind of a core principle of what we do. If we've been to the extent that we can, obviously some data is government data, but research that we do, insights we collect, we want to share them so that we can all benefit from what we're learning, and kind of create that foundation for shared problem solving and performance monitoring going forward. So we're also not duplicating additional insights that are collected and can all start from kind of a common baseline. So I will transition over now to our country experts, and I will hand it over to Rushika to dig into Sierra Leone.
Thank you, Alex, and thanks for going to the next slide. So Alex, I think, set up a great idea of the overall Project Last Mile partnership and how we've approached scaling the entire partnership in close coordination with both our donor partners and in-country partners. And what we wanted to do in the next section is just give you a flavor of how we've approached scale in country in two very different contexts. The first example I'll walk you through is Sierra Leone, and then I'll hand over to my colleague Jose, who will give you an example of how we've approached scale in Mozambique. So if we go to the next slide, just to set the scene on Sierra Leone, which many colleagues on the line might be familiar with, Sierra Leone ranks as a fragile country per OECD's definitions. Since the Civil War ended in early 2000s, the country has struggled with several economic and socio-economic challenges, and about 40% of the country still lives in extreme poverty. There also have been massive gains over the last 20 years in terms of overall development, but challenges do remain in terms of the infrastructure and different aspects that do contribute to ongoing fragility there. In 2013 to 2016, Sierra Leone was one of the countries most impacted by the Ebola outbreak in West Africa, and had the highest caseload of any country in the region during that outbreak. And I think during that outbreak, there was a huge focus, obviously, on the health systems, which is Project Last Mile's area of focus as well. And post-outbreak, there's been a huge focus on looking at the resilience of health systems and building them up. And this was prior to COVID-19. And actually, I think Sierra Leone, a lot of the investments that they made in the health systems helped them respond to COVID-19 better than some fully developed countries as well. If we go to the next slide. So looking at Project Last Mile's role in Sierra Leone and how we started our engagements there. So as Alex mentioned, Project Last Mile's mandate has always been quite demand driven, where we respond to a need raised in country by one of our donor partners. So in Sierra Leone, we were engaged by USAID, who had identified a need to look at how to apply private sector best practices to strengthen the way last mile distribution was happening in country, again, in an effort to continue to strengthen the resilience of the overall public health supply chains. Project Last Mile was invited in to work with the Ministry of Health and Sanitation and the National Medical Supplies Agency in country, which are responsible for the distribution of health commodities through the public health supply chain, and looking at bringing in some of our expertise in last mile distribution, and whether we could apply that to the way that last mile distribution was happening in Sierra Leone. If we go to the next slide. So what we've done in country over time since our initial engagements in 2018 is really take a phased long-term approach to looking at how we can scale up the models, tools, and processes that we have brought in. So when we initially started in phase 1, our focus was really on designing and testing the actual model. When we initially arrived in country, and this is typical in many markets, we typically get a question of, okay, that might work for the private sector, but would it really be relevant, and can it work in this context, especially with the challenges both the public health system faces and the contextual challenges of a market like Sierra Leone. And initially, our focus was really to look at how can we develop credibility for the model and demonstrate that this model can be applied to the health sector and generate results. So our focus was really to engage closely with stakeholders, conduct in-depth assessments to understand the local context, and look at how can we adapt the private sector models that we would recommend to the health sector in Sierra Leone specifically. And at the end of phase 1, and we'll take you through the whole journey and give you a flavor of some of the results. But at the end of phase 1, we were able to demonstrate with some positive results that, yes, you can actually apply these kind of private sector models to a context like Sierra Leone. But in phase 1, we also relied on external resources. We supplemented the existing health system infrastructure with, for example, an external outsourced third-party logistics provider. And at the end of phase 1, what we really wanted to challenge ourselves with in the next phase is not just immediately scaling the model that was tested in phase 1, but really looking at, could we demonstrate that the model could also work within the existing health infrastructure? So not just supplementing and adding additional resources, but looking at within this resource constrained environment, are there ways to adapt the model and tailor it to the local context, but also integrate it into the existing health systems infrastructure, which included, for example, the existing vehicles on the ground, the existing human resources, and how we could adapt the model to work. So our focus in that next phase was really on building buy-in for a specific pilot area to look at leveraging that existing health infrastructure, and then demonstrating how we could adapt and expand and refine the model to work within that existing infrastructure. And at the end of that phase, we also saw positive results and were able to identify shortcomings and areas that we could improve on if we were implementing the model within the existing infrastructure. And where we are now in this phase is really looking at taking all the learnings we had from the first two phases and building the foundation for further national scale up. Now looking at more of a top-down approach where we want to ensure that there is that national capacity at a overall central level in terms of the government overseeing that model, and make sure all the foundations are built for the government to take over and scale and own this model. So if we go to the next slide, we'll just take you through the journey till date and some of the lessons we've learned along the way. So just to quickly give you a sense, as Alex mentioned, our mandate as Project Last Mile is really to look at taking some of the Coke system's best practices and answering the question, if you can find a nice cold Coca-Cola product almost anywhere in Africa, why not health commodities? And our role is really about looking at how we can adapt the models, the tools, the best practices. So not so much taking a Coke truck and just putting medications on it, but taking the tools and the models and the way that Coke would approach a supply chain problem and adapting that to the health sector. And that's also what we tried to do in Sierra Leone. So if we go to the next slide. So starting from the beginning of our journey in phase one. So again, here, the focus really for us when we initially came in country was first to build relationships and credibility and ensure that we had alignment with the Ministry of Health, as well as the National Medical Supply Agency, NMSA, that were overseeing the supply chain there. Again, as Alex said, that's part of our core mandate, is ensuring we are a technical assistance partner to the Ministry of Health and not establishing any kind of parallel implementation or supply chains in country. And so in the first phase, our focus was really on refining and adapting the kinds of models that the Coke system uses that you saw on the last slide to the context of Sierra Leone. And what we found when we initially arrived in country was that there might not have been sufficient resources existing at a district level, for example, to implement a more resource-intensive model that the Coke system uses. So we had decided at that time to leverage external resources just to demonstrate that this model could work within the public health infrastructure. So without procuring additional commodities, just by adapting the service routines, for example, the frequency of deliveries, could you see improvements in out of stocks? And if you go to the next slide, what we saw in the first phase was that by introducing that new model, those tools, changing the frequency, for example, of service visits, the kinds of routines that a driver conducts when they arrive at a health facility, we were able to see large reductions in out of stocks through introducing those interventions, and able to demonstrate that kind of model where we were able to adapt the service routine at the last mile, that in itself could help introduce improvements in the target outcomes that the Ministry of Health had. So if we go to the next slide. So in the next phase, a key challenge for us, as I mentioned, was really looking at, okay, we've now demonstrated that this model can work in the public health context of Sierra Leone, but can we make it work if it's integrated into the existing health infrastructure? So not just focusing on leveraging, for example, an external outsourced third-party logistics provider that might not be sustainable at scale in the resource-constrained environment that we were operating in Sierra Leone. But are there ways to tweak and adapt the model to work within the resources that are available? And a key additional aspect that we introduced in this phase was also looking at how we could respond to the Ministry of Health's requirements and the strategies that they were implementing. And a key ask from the Ministry of Health as we were approaching phase two was how to, for example, integrate a new element into our model, which was a digital component to increase real-time data visibility of inventory down to the last mile. So we also then incorporated, expanded, and refined the model to integrate into existing infrastructure, but introduce this new element of a digital tool and see if that could also have the desired outcomes that the Ministry of Health was aiming for. And if we go to the next slide, What we saw in this phase similarly was that even with tweaking the model, with reducing the service frequency, with trying to adapt the model to be implemented with less resources, we were still able to try and get to the target outcomes that the Ministry of Health and NMSA had in terms of seeing improved reporting rates, seeing reductions in out of stocks. And there were a lot of learnings for us also in terms of introducing new components like the digital tool at this stage. So when we were then engaged to look at a next phase of work, before we recommended just taking this intervention that had worked in a specific context and immediately going to scale, we worked with the National Medical Supply Agency and the Ministry of Health to really align on what their national long-term vision was, and look at how we could make sure that the model that we were recommending aligned with that. And a big piece in this phase, for example, was the tool that we used, the digital tool that we introduced in phase 2 wasn't quite aligned with where the national stakeholders wanted to go in their long-term strategy. And so a key area that we looked at in phase 3 was really shifting from being focused on our model and the intervention that we were bringing to the table to looking at what was the outcome that our stakeholders were trying to achieve and trying to sense check, is the specific digital tool, for example, that we're putting forward, if we do switch to a different tool, will it actually impact the target outcomes that our stakeholders are wishing to achieve? Or is it more important to make sure that it is aligned and we're not investing in a completely parallel tool, for example? And we were able to pivot the intervention and the overall model to make sure that it was aligned, and we were able to align with where the Ministry of Health and the NMSA were going in terms of their digital strategy. At the same time, I think having that more outcomes focus of what are they trying to achieve versus just trying to get our specific model to scale, we also were able to identify that the types of outcomes that the Ministry of Health and NMSA wanted to achieve would never really be achievable without addressing the core supply chain challenges that they also had at the last mile. So we were able to be flexible in terms of what is the digital tool you use, but where we decided to really put our efforts in making sure they could achieve their outcomes is making sure they were able to integrate some of those supply chain processes and tools that really helped achieve the outcomes that we did in phase 1 and phase 2. So if we shift to the next slide, I think just to touch on lessons learned and make sure that Jose also gets enough time to go through Mozambique's examples, I think some of the key lessons that we've learned through this process is, I think the first piece is what I was mentioning on the last slide, is looking at how we can make sure that whatever intervention we're putting forward, once we get to the stage where it's been demonstrated and we're looking at what to scale up, making sure that that intervention or that model can be adaptable and agile to the needs on the ground, and looking at how you can make sure that intervention can focus on the outcome versus just the model itself. So not being so stringent that you need to have this exact amount of resources or implementation to really make this successful, but really focusing on, are there ways that you can keep the model adaptable to respond to the evolving needs on the ground, but staying outcomes focused in terms of what you're trying to achieve. The second area is, I think it's really important to build an implementation plan that allows you to demonstrate replicability within different local contexts. So even within a country, even within a district, there are such differences in some of these contexts, both from a security point of view to an environmental point of view, that being able to build out in enough time to demonstrate that the model can be replicated, and also stress testing the model itself so that it can be adapted to these local contexts is critical in order to both build credibility and make sure that the model is sound. And then the last piece is, I think that this kind of scale up really does take time, and allowing enough time to, first of all, build those relationships with stakeholders and allowing enough time to build buy-in and alignment prior to full national scale up is critical. I think even with the best model in the world, if you come in immediately and are looking to go from a small pilot immediately to national scale, there will be potentially several missteps along the way. So ensuring that there is time to have that buy-in, allow the model to show that it can be adaptable and replicated in different contexts is an important learning I think we've had through this project. And with that, I'll hand over to my colleague Jose to give you a flavor of some of our learnings from Mozambique.
Okay, thanks, Rushika. Hi, everyone, and great to have an opportunity to share something about Mozambique with you. So Mozambique remains one of the poorest countries in the world. So it's not surprising that it is classified as one of the hard and fragile countries. Yes, it has many challenges, including economic, environmental, political security, and unfortunately, it also has its fair share of natural disasters. The geography of the country is tough. It's about 2,500 or even up to 2,700 kilometers from north to south. It's a fairly long, narrow country. The infrastructure is not all that well developed and poor. So it is tough for the Ministry of Health to really meet the needs of the country from the health system's point of view. So it's not as robust as it needs to be. Having said that, there's a lot that's positive and great, and I believe that the future is bright for Mozambique. It does have high rates of GDP growth, admittedly off a low base. It's very rich in natural resources. Tourism is growing, and also there's more financial stability and currency stability now. So given the leadership and the vision of the country, the future is bright. Nevertheless, it is a tough place. I have lived. I don't live in Mozambique now. I live in a neighbouring kingdom of Eswatini, but I have lived here for 10 years in the past. And just as an example, if we go to the next slide, a few years ago when we were doing the work on region optimization that I'll tell you more about now, in a 2-week period, this is the kind of issues that we dealt with in the country. There were brutal attacks by insurgents up in Cabo Delgado. There were cholera outbreaks. There was destructive flooding in the country. But I'll tell you a bit more about how we overcame these kinds of challenges in Mozambique once I get to the slide or some examples of how we scaled up. So that was to try and share with you a little bit of the context of what is needed and the conditions under which we operate in Mozambique. I'll give you some specific examples of scaling and how we address the needs, and then also what some of the key challenges and enablers are. And I'll end off by sharing with you some thoughts from Project Last Mile in terms of how we can best maintain scale. In terms of our history, Project Last Mile's history in Mozambique, we've been operating for some 5 to 6 years in Mozambique actively, and it started off very low-key and small. The initial project was just had a 9-month time frame, which is pretty tight, and it's where we started off by doing the route and optimization for just one of the 11 provinces in the country, and we also teamed up with an implementing partner in Mozambique that you may all know, Village Reach, where the first pilot of what was then a fairly new concept in terms of outsourced distribution was taking place in Tat City in Mozambique, in central Mozambique. So we partners and we as Project Last Mile contributed in terms of the access and knowledge that we had from the Coca-Cola system when it comes to working with outsourced distribution. I'll just now about how that has expanded to where quite incredibly it is today. After that, in the 2 years following, we were able to continue and finish the region optimization work across the whole country, except for one province, Cabo Delgado, which was a challenge, and I'll tell you now about how we addressed that. We also in 2020 proposed, given that by then we had a better knowledge of the health system in Mozambique and the areas that could do with some strengthening, and we proposed to the Global Fund and to the Ministry of Health. We made a proposal in terms of how we could work with the central medical stores. It's called CIMAM in Mozambique, but I'll refer to it as Central Medical Store or EASE. And we made a proposal in terms of implementing what is known by some as a VAN, or Visibility and Analytics Network. The idea was that there be visibility and the ability to manage the supply chain end to end in Mozambique. So we worked, the proposal was accepted, and we worked in terms of designing a new operating model, reorganizing and designing an accrual-based accounting system for the finance department that was closer to what is needed for entities that work in the private sector and with autonomy. And also we worked with partners and a state entity, by the way, to design the strategic plan for the information systems for the next 10 years. So following that, in 2021, we made a proposal, given that the work that we'd done in 2020 was more of a design and theoretical nature. In 2021, we made a proposal again to the Ministry of Health and to the Global Fund to fund it in terms of how we could work with the central medical stores and partners in Mozambique to implement those elements of that we had worked in terms of design of the operating model and information systems, etc. So in 2021, we also started something that was quite new. It's not new, but it was an opportunity to combine demand creation with improved availability and route to market, and that was around working with the National AIDS Council in Mozambique on a condoms project. So we put together a team, and we embarked on a project, first of all, to increase demand for condoms in the country, and then to back that up by increased supply and availability. And that was really to address the very high infection rates of HIV in the country. And also to address the low rates of use of condoms. In 2022, we began the work around implementing the design of the new operating model, the information systems, or the strategic plan for information systems, and so on. And that is what we are involved with at the moment still, and it will run through until the end of this year. So let me move on now, in the interest of time, to some examples. Now that I've shared now a picture of what we've been involved in Mozambique for the last couple of years, an example, or some examples of where, despite the challenges that we faced in this country, we were able to scale things up. So first of all, I told you that when we first started back in 2018, we collaborated with Village Reach on a pilot for third-party distribution to the last mile, to the health centres in the country. And Village Reach was leading that. We were really just a supporting partner. And Village Reach then expanded that into a neighbouring province in Aban province. And it's quite exceptional, in fact, that now, some 5 years later, third-party distribution and even managed by a 4PL in the country, which happens to be Bolaray, has been implemented in the country. So it's quite interesting to see that a new concept that was piloted in one city only 5 years ago has now become the way that the Ministry of Health goes to market in the country, or not goes to market, but actually delivers medicines to the patients, the users at the end. Another example is the sharing of 3PL tools. Again, that started back in when we first worked on the pilot in TAT with Village Reach, and given our access to the Coca-Cola system, and bearing in mind that the Coca-Cola system in many countries in Africa for most of the smaller retailers and distribution points for their products, they don't do the distribution themselves. They use third parties to do the last mile distribution for effectiveness and for cost management purposes. And so we had access to all of those tools, that knowledge, the know-how, and we were able to share those with Village Reach and also with the central medical stores, and it contributed to the story of where the system is today, that all the distribution to the last mile across all 11 provinces is done by third parties. In addition to that, we supported Village Reach in developing an outsourced distribution toolkit that is now, it's been translated and is available in Mozambique, and where one can access all the tools that can be used with 3PL management. On the private sector engagement and supporting routine optimization, we started in just one province back in 2018 in Gaza province, and we went on over the years to implement that across the whole country. But I'll tell you, of course, that there were challenges, and I'll talk to just two. Of a different nature, one to do with security and one to do with Cyclone Idai. So there were in Cabo Delgado, where some of the biggest gas finds in the world are now being developed. There's an issue there with security and insurgents, and it was at the time that we were needing to go into Cabo Delgado. It was the last province. We've done all the other 10. It was the last province where we wanted to do regional optimization. So we sent up, and regional optimization, just by the way, meant physically driving to every single one of the 1,600 or so health centers in the country on the roads, so that we could assess the nature of the roads, the speed at which we could drive, so we could identify the right vehicles, and also the cost of doing distribution to all of the health centers in the country. So the point is, when we got to Cabo Delgado, we had the security issue to deal with. So we did send a team up to meet with the Ministry of Health authorities in the province, and we also connected with some security advisors, and they advised us that there were 9 districts in the province that we should definitely not go into, and we didn't. And we were going to do just one of the main cities there, or districts, which was Pemba, but matters were not looking good there, so we ended up not going into Cabo Delgado province for security reasons at all. So what we did instead is we did, whilst in the rest of the country we had physically driven to every single health center, in Cabo Delgado we chose to rather do a desktop exercise, using information that we gathered from partners. We used open source platforms, and for the road network that was known, we used the TomTom road network that we could access through technology. So that's an example of what happened in Cabo Delgado. Cyclone Idai was one of the worst natural disasters that happened in the central part of the country, and we were busy, in fact, with the regional optimization in the Sofala province when Cyclone Idai hit. If you can just move to the next slide, I'll show you a few graphics of that. So what you see there is the province of Sofala that was worst hit by the cyclone. When the cyclone hit, or we could see it was about to hit, we'd only finished doing the route and optimization, mapping the road network and the speeds even at which we could drive on those roads. We'd only done 4 districts, about 25% of the province. So we obviously removed our teams from there to safety and the vehicles that we used. and then the cyclone hit, and there was terrible devastation. So after that, what we did is we packaged and shared the data that we had for the districts that we had done with partners and with the Ministry of Health to aid in rehabilitation and aid relief. We went on a few months later, we returned to Sofala province, and we were still able to visit and map 166 of the 170 health centers in the province. So we did manage to complete 98% of it. If we can go back to my previous slide, examples on scaling, just so I can finish the last 2 points. Thank you. Around just another example, we were asked by Africa Resource Center and the GFF to do a viability study on whether 3PL distribution will work in Mozambique. So it was a short-term exercise, took us about 2 or 3 months just to try and determine the appetite for that. And that led to a bigger study where we worked with global partners and the private sector group for innovation in supply chain. And we ended up actually doing a whole network redesign for the country, building on what had been done in previous years. And we introduced a new private sector concept of cross docks. I don't have time to go into that now, but it's basically a skeleton kind of warehouse that leads to greater efficiency and lower cost to do distribution in a country such as Mozambique. And then the last example is, I spoke a bit about where we did the van introduction, and that's led to that we are busy with this now, is implementation of a new operating model. We use the SCORE, the supply chain operating reference model, as the framework for that. On the capability development side, we've also used work by Essential on the human resources for supply chain management. I think it's also been done for or in conjunction with people that deliver. So we're busy with that now. With the central medical stores, we're busy with the we've done the design, but it's really the implementation now of the finance reorganization and to strengthen the procurement department, and also with the implementation of the strategic plan for information systems. Okay, so to conclude, let me just summarize I think I've touched on them during the course of my intervention here, but summarizing the challenges and enablers for you. So some of the challenges that we've had, and these may be specific to Mozambique, but I think they happen everywhere, so they are relevant really. So not only within the Ministry of Health and central medical stores, but even with donors. I mean, change is inevitable, change happens, and it's important that we stay the course. Project Last Mile has gone through many dead spots in the last 5 or 6 years that we've been operating in Mozambique, but we've been able to stay the course. We haven't, when there's a dead spot, we haven't packed our bags and left. And I think that's enabled sustainability and continuity. Another challenge is the lack of resources and productivity at a central medical stores level. And that is, I mean, it's not because they want it to be that way, it's just because of the nature of the challenges and the needs of the country. It's a very complex country, it's a large country, and the central medical stores is under-resourced. Unfortunately, every day does involve the fighting of some fires, and so everybody is stretched. There aren't enough resources and there isn't enough time. So that is the environment in which we are operating. Supply chain professionalization, by that, in the central medical stores, traditionally, pharmacists and medical people, doctors, have been involved in the central medical stores. And you'll know that what you really need there to a large extent is supply chain and logistics people. So there is a move toward to have more of the leadership, qualified in supply chain logistics, but there's some way to go on that. A lack of funding is another issue. Alex spoke about that as well. Big derators. Sorry, I just need to take some water. So I've spoken about those conflicts, cyclones, politics, and then the language issue, which may be specific to Mozambique. But in terms of enablers, so we found that good governance is a very important part of sustainability and continuity and good relationships. So we always worked with a steering committee that's well constituted. It includes the Ministry of Health, donors, and partners, and that's been very effective. We to support the steering committee, we also have regular reporting routines. M&E, obviously, if you can't measure it, you can't manage it. Relationships, our routines really enable us to maintain the good relationships. Another thing is partners integration. I've spoken about Village Reach and how we've worked with them, but it's also important. Mozambique has a very busy landscape in terms of partners and donors, and it's important. There's so many programs. It's important that there's some kind of harmonization and integration in that. And then the private sector lens and access. For Project Last Mile, it is a point of differentiation. We have close access to the Coca-Cola system, which is a world leader in logistics and supply chain, and it is what makes Project Last Mile different to many other implementing partners, is that we bring that private sector lens to everything that we do. And then I've given examples of that. Readiness and ability to scale up nationwide is very important. To conclude, I hope I'm doing okay for time, but this is my last slide. Around how do we scale up? If you can go to that slide. Okay, documenting, having a skills transfer plan is fundamental for sustainability, for capacity and capability building. And it's not, so don't just talk about it. We really recommend that you put it in writing, you have a document that talks to who's going to be trained, or the skills and knowledge transferred to, by when, on what, and how is that going to be demonstrated. So be formal about it, document it, and that will make it work. Make a difference and stay the course. I've given many examples of the challenges we've had. Don't do things that are just ad hoc or location specific or time specific, because that doesn't last. Yes, you might make someone happy or make something work for a short period of time, but that doesn't make it sustainable. A roadmap for enablement, I've touched on that already. There are many partners, many initiatives, many programs in the country, and it's important that there's some kind of alignment or coordination. It will really help strengthen the supply chain and the health system dramatically. And then leadership engagement, I've touched on that. We really believe in that. Good governance, good reporting is important. And then we're not, well, Mozambique in any case, we're not ready yet. I know the desire and the vision is there for the country to be self-sufficient in every respect, but we're not there yet. And for now, we do need ongoing catalytic donor funding. All right, thank you very much. I hope I didn't go too much over time. Thank you.
Thanks, Jose. I think I'm going to come in with one last example and then turn it over to Alex and our chair just to open up for questions. So we wanted to give just one other example of South Africa, which it does not qualify as a fragile setting, but in terms of some of the challenges that South Africa has faced in the last few years, just wanted to give you a little bit of a different example of another program operating at scale there and how we've supported and pivoted and adapted our focus there. So in South Africa has the world's largest population of people living with HIV and manages the world's largest ARV program of patients continuously accessing chronic medication to manage their HIV. So because of this, obviously there's a huge burden on the public health system for patients that are showing up for routine access to their chronic medication, showing up month by month to collect their 30 days of medication, for example. So in about 2014, 2015, the National Department of Health in South Africa really started looking at how can they help, first of all, increase patient access to ARVs, so solving the patient access issue, but also reducing burden on the public sector to move patients out of the public sector for routine medication dispensing, to reduce the burden on health facilities that were getting overcrowded with long lines for patients just to access their medication. And the solution to this problem was a model and a program that the National Department of Health developed called the Central Chronic Medicines Dispensing and Distribution, or CCMDD program. This program was really a decentralized drug distribution program that looked at how to move chronic medication distribution outside just the public health sector. And for example, activating retail pharmacies, smaller community pharmacies as pickup points where patients could show up and get their medications still for free, but from a private sector pickup point that was closer to home, and move patients out of the public sector. So if we go to the next slide, Project Last Mile came in about 2016 to support the National Department of Health look at how they could scale up this program, working closely in partnership with the private sector to look at how to, first of all, develop out a business case for private sector partners that were engaging in this program, and developing out a quantified business case for why would, for example, a private sector pharmacy want to participate in dispensing free medication. And part of our role was to develop out a business case, for example, for private sector pharmacies to understand what the additional footfall could mean in terms of revenue that they would get from being able to dispense and expand their patient pool. Over the years, we've been able to support the National Department of Health massively see a scale up of this program, where it started with under about 500,000 patients in 2015. And since our support started, it now supports over 5 million chronic patients nationally. And a big part of this program was that there was government buy-in from the beginning. So it was a government-led, government bought-in program that the domestic government of South Africa was also funding. However, there wasn't really that capacity from a strategic perspective to look at how to partner with the private sector to really scale this. And from 2016 to 2020, we were supporting the government in really setting up the foundations, for example, setting up standard operating procedures, contracting mechanisms to engage private sector entities, all the infrastructure they needed to actually establish and scale this program. If we go to the next slide. So while all of this was developed in South Africa during periods of stability, what we found from 2020 onwards was in the last 2 years, South Africa also faced several disasters, both in terms of the COVID pandemic, as well as a series of civil unrest, as well as natural disasters such as flooding that affected certain provinces. So an example of these disasters that came up and affected the stability and operations of this kind of system, there were about 400,000 patients that were influenced by civil unrest and floods, or impacted by civil unrest and floods, for example, in the last 2 years. And because of the foundational systems that we were able to set up, as well as the ability to support the National Department of Health in rapid scenario planning and business contingency planning on how to adapt and evolve their standard operating procedures, we were able to ensure there was no significant patient drop-off despite this flooding and unrest. So I think this example we just wanted to highlight as an example of, even though this wasn't a fragile setting, even when there were disasters emerging, some of those foundational systems, setting them up in a way that enabled them to adapt and evolve, even when unrest was around, was critical, and allowed these systems to operate at scale and still adapt to reduce any impact on patients. So with that, let me just hand back to Alex, I believe, and we'll open up the Q&A.
Great. Thank you, Rushika. Thank you, Jose. And thanks to everyone for the questions that have been coming through. I think we have been able to answer a couple of them. So we'll definitely continue to take more. I think one set of questions that we haven't yet addressed was around Coke engagement and the shared value perspective and how countries responded to that. So this is very intentionally a philanthropic initiative of the Coke system. So it's funded by the Coke Foundation. It's not funded by the Coke company. And so shared value from the perspective of generating value back to the business is not part of the focus of PLM. And so that was not a requirement from a Coke system perspective to engage in this initiative. And actually, it's been quite separate intentionally because it's funded out of the foundation. I will say that in terms of the response we've gotten and how to, I think the question was how to keep it from being perceived as a kind of a marketing focus. We've been very intentional, I would say, in under marketing this work because we really wanted to demonstrate the impact and build the trust more than promote it from a marketing perspective. I will also say that we really don't, like Coke system and Coke we don't do any marketing of this work from a Coke lens, and if it is, it's very limited in going out to Coke channels versus consumers directly in country. It's really more been a focus on sharing within the global health ecosystem what we're doing, what we're learning, and how we're delivering impact. So I would say there's one example I have in mind, maybe two, but for the most part, what we really put forward is the private sector lens, which more and more countries and organizations are really getting interested in. And we don't really put forward Coke directly through our work. So by having PLM also as that intermediary brand, as a brand in and of itself, it kind of separates the Coke system from the work we're doing anyway. So the way we speak about it is that we're leveraging the best practices and expertise. And frankly, as soon as, in most cases, when we sit down with people and we're like, all right, have you ever heard of the Coke brand? Or have you been to a location where you haven't been able to find a Coke product? Most importantly, people are intrigued and they really do want to learn from that. And that's taken precedence over questions around, the value back to Coke as a business. So yeah, I hope that answers your question on that point. I know there are a few, so I'm trying to make sure I catch everything else. I think the others have been answered. Do the involvement or prominence of Coke complicate credibility and access? Yeah, so I think I addressed that. There's in one country in particular, there was a specific request to not engage on the Coke side to kind of pull that back, and so we did. Again, we're focusing more on the private sector and the practices we can pull through than the company, but the company doesn't directly engage with ministries of health or our implementing partners on behalf of PLM. That's all kind of a neutral PLM engagement model. I think the Coca-Cola as a pull system was answered. We've also answered questions on kind of sustainability and our exit strategies. Seeing that it has gone through. So Rushika, maybe can I kick it to you for your reflections on the sustainability question, and Jose from a perspective on the countryside?
Yeah, absolutely. And I think sustainability in any development program is always the golden question of how to make sure these kind of interventions can be sustainable. And I think we approach it in a couple of different ways. So one of the core pieces, I think, because PLM's mandate is not to be a kind of standard implementing partner. We're really coming in as more of a strategic technical assistance partner. Typically in most markets, we're not putting down massive implementation infrastructure or setting up kind of parallel implementing, implementation arms. So wherever possible, the models that we're designing, I think the examples we gave hopefully highlight that as well, are all meant to be integrated into into whatever existing infrastructure is present, whether that's managed by the Ministry of Health or implementing partners that are around and supporting and supplementing the public health sector. So we are always kind of designing the models up from the beginning to make sure that they can be integrated, because we know that we do not want to be there after, for example, demonstrating the pilot. We are not going to be around to help the Ministry of Health take this forward. So we are always taking that lens from the very beginning. And a huge part of what we try and do up front is look at what is the business case. Is the model we're putting out to the Ministry of Health actually going to make sense in terms of the ROI and the return on investment they're going to expect from that? So we are really looking at sustainability from that lens in terms of, from the beginning, the design of the model itself should incorporate that. And I think the other piece is, over time, a lot of the work that we do, the last South Africa example we gave, for example, is supporting models that are already owned and managed by the Ministry of Health, for example. But it's really about how can you streamline, gain efficiencies, and strengthen those models as well. So while in some cases there will be requirements for donor funding to supplement the Ministry of Health investments in certain models or certain programs, a lot of the time our role is really to look at how to increase the efficiency of the investment either the Ministry of Health or the donors are putting in, and in that way increase the sustainability of a certain program.
Yeah. If I may add some thoughts about Mozambique, I can't speak for every country, but certainly for Mozambique and a few other countries I've operated in, we don't actually do anything. I mean, we don't distribute, we don't warehouse, we don't supply. Our job is really just to share knowledge and to build capability. And I did, for example, speak about the region optimization that we did in Gaza province, and then we expanded to the whole country. We took along 3 different individuals on that journey from the Ministry of Health and partners, and we trained them on how to do it. And in fact, when we left them with a laptop with all the technology and the software that we use to do that on the laptop. So that's an example of where the Ministry of Health is or should be capable of doing the routine optimization work themselves in the future.
Thanks, Jose. Thanks, Rushika. Okay, what else do we have here? So Shreya asked a question about, is it important to get government buy-in from the start? In our experience, I would say pretty much yes, across the board. I mean, again, our interventions are for the most part designed to support public health systems. So in order to be able to make any sort of impact on that, having that endorsement and buy-in upfront, even if it's to try something new and not necessarily, there's not necessarily buy-in upfront that there will be scale. And I know that was another question of, do you set a scaling target for each country nationally? Not necessarily. I mean, it depends on really what the strategy is of the government and how it can align with that. I think in some cases it might be focused on regional versus national. It's not necessarily built into a national scale target for every market. It is intended to be quite demand responsive to what the ministries of health are looking to do. I will also say in a number of cases, and this is changing now that we've been around, but it was also a lot of a learning lab, a lot of testing if and how and which components of the Koch models can work. So when we were getting started on that, we needed kind of the trust and the intrigue from our partners to say, okay, we've seen this work in private sector. We're open to seeing how, if and how it can work, you know, in your pilot phase. And then once we've been able to kind of expose partners and demonstrate that ourselves, then we look at, is this a national scale opportunity? You know, where's the best fit for how this should grow? Any other questions? And Rushika or Jose, if you're seeing other questions, please just jump in, or Jonathan. I'm looking through the list here. In terms of application to other sectors, I mean, our focus is on health, but I certainly think there's applicability across sectors. We, you know, our mandate is in health, so we haven't applied it, but definitely definitely applicable to other sectors. Is there a country that PLM has successfully exited? So we're still in a lot of the countries that we started, which I think goes to the question around, is there kind of a time estimate for how long you are in countries? I think we really focus on depth in those markets. And so I would say the country that we've exited, where we've kind of fully exited and have seen those models stick, was Tanzania, particularly with a focus on their performance management from a talent management. So they had implemented a model called Drive as part of their HR, and that was sustained long after PLM has exited. Other than that, we're really still in a lot of the countries where we've started our work. So we can't yet say that we've exited because the portfolios have both grown in kind of starting to layer on other value and service offerings that PLM has. So if we started, often we'll start with one kind of service line, so focusing on strategic marketing. And then as the needs in the country and the trust is built around PLM's capabilities, will be brought into cold chain or brought into route to market, or looking at how we can layer and integrate those service lines. Because our ideal would be to be supporting across the board on both matching the demand creation with ensuring supply. So we're doing that in Mozambique. And to the extent it's possible and makes sense in other markets, CCMD South Africa is one where we also did a marketing campaign that would help create a brand for that differentiated service delivery model and drive patients to it. That's really what we're looking to kind of go to as the next step.
That's great, Alex. And there's one last question maybe around, is there ever any conflict of values in trying to reach the least accessible recipients versus some that might be more influential or have a bigger market share? Was there ever a kind of a conflict that had to be smoothed out in getting to that real last mile?
Not directly, and I'll also ask Jose and Rushika to chime in from experience recently on the ground. I mean, the reality is it costs more in a lot of cases to get to those places. So it's a conversation around cost. But there's never been, I would say, a conflict of values. I think it just comes down to making hard choices around being in a resource constrained environment of, you could spend this amount of money and reach this group of people, and the additional spend to go further will be higher. But if you're looking at it from an equitable perspective, it's not a private sector mindset of reaching as many people necessarily as you can for the amount of money that you have. It might be looking at who's not reached, who already has access to those services, and then that might mean allocating resources differently. So I wouldn't say it's a conflict, and Jose, definitely please jump in. I would just say it's a different approach because you're not necessarily looking at reaching the most people always in a circumstance. It depends on what the priorities are, but you also have that equity lens that might not be exactly the same in the private sector.
Yes, I can add, this question is especially relevant to outsourced distribution and to the last mile. I mean, do you do it yourself with, this is the Central Medical Stores, Ministry of Health, do they do it themselves with their own vehicles and own resources, or do they contract a third party? At first sight, it looks like a third party is more expensive, but I can tell you, and I think the data and the experience proves it, is that in the long term, it is cheaper if you pay a specialist service provider to do that. The truth is that the Ministry of Health, it's not a distribution, and in Mozambique's case, that's been recognized. Distribution, managing trucks and fuel and maintenance and spares is not a core competency. You know, and in the long term, if you look at the efficiency and costs over the long term, it's definitely it works out more effectively, more effective value to use third parties. But ultimately, to me, the more important criteria is actually availability of medicines, because that's what you want. I mean, huge amounts of funds are invested in the healthcare system and in supply chain. What really matters is making the medicine available at the point of need, at the right time, at the right place. And certainly if you have a reliable distribution system to the last mile, then you can better guarantee that.
Well, this has been an absolutely fascinating and important conversation. Warm thanks to Alex and Jose and Rushika for the deep dive into Project Last Mile. I'll call out just a few key elements that we talk a lot about in the scaling community of practice in terms of what success looks like and what's required, and which Project Last Mile really delivers on. The first thing is not to treat scaling as something that starts with an innovation or a successful pilot, and then if that is successful, goes to scaling as a secondary process. Scaling is really an organizing framework that helps you start specific types of pilots or innovations in ways that are thinking about political authorization and support, social acceptance and engagement, having the financing streams to go the distance, and then also having a coordination element, a backbone, which GETF provides in this case, to really ensure all the pieces are moving together and all the various parts are aligned. And so we see that with Project Last Mile. The other piece that's just so fundamental is that there wasn't one particular model or digital platform in the case of Sierra Leone that was used to scale. It was really about scaling an outcome, being able to provide health solutions at the last mile. And when you have the outcome as fixed, but not a particular innovation or model, you can be very flexible in terms of the pathways you take to try to get to that outcome. And you really see this in Project Last Mile, being able to pivot as needed, to continually test and adapt the various pathways to getting to where it needs to go. And this provides that extra dividend, which I would think of as the resilience dividend in these places that were very difficult. And I would even include parts of South Africa in times of the instability and the disasters that Rushika talked about as being that sort of a fragile context within the country. That ability to pivot and to be able to find new pathways around disasters, or around instability, around other kinds of shocks, really contributes to the sort of resilience perspective that we try to cultivate within our group as well. How do you work in hard places not to just deliver a developmental solution, but also contribute to the resilience of people, communities, the health system, the supply chain, and so forth. And so that is coming across in Project Last Mile too, in terms of one of the winning characteristics. The other piece that really struck me is just the social aspect, the really close brokering community engagement that runs through the entire piece. When you talk about advanced logistics and market delivery and supply chains, there's always a risk you can be thinking about very technical kind of desktop exercises or very formulaic linear processes. And Project Last Mile really delivers a much more iterative kind of social approach to this. And I think that's part of what makes it so successful. So thank you again for such a wonderful presentation. We will have the video on our website. We'll also have a slide deck, this slide deck on the website as well. Many of you have trouble accessing it, and so we'll definitely make sure that you have a copy of that you can resource from the website as well. And thank you very much again for joining us today. Thank you to all of our participants, and again, a special thanks to the Project Last Mile team.
Thank you so much for having us, and we're happy to stay in touch and connected. If anyone has additional questions, please feel free to follow up.
Thank you.
Thank you, everybody.